Hello everyone, this is Dr. Viswanath, Aluru, attending physician in physical medicine and rehabilitation at Oxnard Health in New Orleans. In this video, we will continue with our topic admissions in patient care section. Last video, we were discussing about admissions, but something that I wanted to tell you is if you are not an on-call resident and if you signed up all your patients under your service on-call person and you went home, you came back next day morning, you got the sign out from the on-call resident. Three things might have happened. One is there might be a patient that some other department have consulted your service and the patient was already seen by on-call person. That means they have put in a consult note with recommendations after discussing with attending. But now the patient went to surgery or still in the emergency room, but now the admission did not happen. So the attending decided to bring this patient to the service, so you have to do the admission for that patient. That's one scenario. Another scenario is there was a patient who came overnight as a direct transfer from another hospital or another facility or a transfer from another emergency room, and that patient was already admitted to your service and you're attending. That means the on-call physician has already completed the admission process, including admission orders, medication reconciliation, or admission notes, and everything. The only thing is that you did not know is about the patient because this is new and everything happened overnight. There might be another situation where someone might have consulted your service or on-call resident to see a patient, maybe in the emergency room or some other department, but that process is still in progress. It's not completed yet. So when it happened, like towards morning, like 6 o'clock or 5 o'clock, sometimes what the on-call physician do is they will simply sign out that patient to you. That means it's on you to actually complete that process of admission. Either go see the patient first, do the examination, and then discuss the attending, and then bring the patient to your service as a new admission. So these are the various situations or scenarios that can happen when you are not there on the service, when some other on-call resident is actually dealing with the service overnight until you get the sign off in the morning. So with this, I'm going to end the admissions topic, and we will move on to discharge. Imagine a patient was admitted to your service and the patient was under your service for like 1 week or 10 days, certain amount of time. Now it's the time that you decided, okay, the patient needs to be discharged. So most of the situations, what happens is most of the times patients come to the emergency room and they get admitted to the hospitalist service. The hospitalist will do the admissions and then they call appropriate specialty consult as needed, or sometimes they just manage the patient without any specialty consult if not necessary. And then when they're medically stable, when they are ready for discharge, then they have to decide whether the patient is stable enough to go back home. Do they have a safe discharge plan? Or if the patient is not stable, what are the other situations? There are certain possibilities that can happen. Either the patient go to some other service in the same hospital, some other department. Imagine the patient was on the medical unit, right? But the patient condition worsened. The patient might go to ICU service or CCU service or a neuro ICU service, or the patient might go to a neuro service, or the patient needed a surgery. The patient go to one of the surgical departments like ortho surgery, general surgery, neurosurgery, whatever it might be. Or the patient might be on the floor, and then but the patient presented with significant impairments or disability issues where they cannot go back to the previous functional level. In that situation, the hospitalists think that the patient might need intensive rehab therapy. Now, in that situation, what they do is they actually have to put in a PM&R consult, so that one of the PM&R physicians or PM&R nurse practitioners or liaisons, whoever it is in the hospital, they will go see this patient. They also request physical therapy, occupational speech therapy evaluation at the same time on the acute care side, and then to decide whether the patient does actually need acute inpatient rehab therapy, or the patient is medically stable enough or be able to tolerate intense therapy. That's one scenario, right? If the patient cannot go home, it's either intense inpatient rehab therapy, or if the patient has severe like medical needs, like say if the patient is on vent management or if the patient is on trach or peg tube feedings or IV antibiotics or significant wound care needs, the patient might go to some other inpatient care called long-term acute care (LTAC). Or in some situations, the patient might need continuous inpatient nursing, inpatient therapy. So in that situation, the patient might go to a skilled nursing facility. Or if the patient does not have any kind of support, or if the patient is not making like enough progress, or if the patient needs round the clock nursing service, the patient might simply go to a nursing home, right? So these are various situation scenarios where the hospitalist or the admitting physician or surgeon might look into where to transfer this patient from here, right? So in that situation, either it becomes a transfer from one department to the other department, or it becomes a discharge. Imagine, because I'm in a rehab setting, we usually get requests from the acute care side, acute hospital, from various departments. It might be internal medicine or general surgery, neurosurgery, neurology, whatever department. We get requests from all departments to admit patients to acute inpatient rehab service. So that's actually, so they are going to discharge the patient from their service, and we are going to admit the patient to our rehab unit. So this becomes a discharge and admission. Say now we have admitted this patient to acute inpatient rehab, right? Now the patient stays here, say about like 2 weeks, and now the patient is ready to leave our rehab unit. In this situation, now the patient might actually go home. In most of situations, almost 90% of the situations, patient usually go home from acute rehab service. But in certain situations where the patient is still making progress but not enough progress to go home directly, or the patient does not have enough support at home to go, or the patient needs significant help, assistance when they go home. So these are situations where we cannot discharge the patient home safely. In that situation, we have to decide where else the patient can go to. Does the patient go to a skilled nursing facility? Do they qualify? Or the patient go to a nursing facility? Or do the patient need to go back to like acute care, like because for some acute medical management or for some acute surgical management? So these are the things that we talk about in our team conferences to see, like, how the patient is progressing in therapy, whether they can safely be discharged home with home services like home therapy or home health care, or does the patient need to be in another inpatient setting like a skilled nursing facility where they get round the clock nursing care and they also get some therapy, not that intense therapy? Or do the patient need to be in like a nursing home because if they don't have a home or they don't have help at home, so at least they can get some nursing care when they go to, or can the patient go to like some kind of assisted living facility where they can live fairly independently? So these are the various situations or scenarios where you have to decide and discuss with your team what's appropriate. So when that situation comes, that means you have to initiate the discharge process. So either it's a discharge from like an acute care hospital to home, or from an acute care hospital to some other facility like inpatient rehab or an LTAC or a nursing home or a skilled nursing, whatever it might be. So there are different types of situations where you have to discharge the patient from the service. So when this discharge process comes, it has to be as thorough as an admission process. So there are several steps involved in the discharge, especially when you're discharging patient home from a rehab service. You have to plan far ahead of time because the patient might be going home, or the patient might need some equipment like, we call it DME or durable medical equipment, like, like wheelchair, bedside commodes, walkers, these kind of stuff they need when they go home. And then the patient might need to go home with home services like home health care, home nursing, home wound care, home therapy, or home infusion. So these things we have to set up, we have to arrange, and they take time because the equipment need to be delivered to the patient home before they actually go home. All the home services need to be set up before they go home. If the patient is on dialysis, we have to set up outpatient dialysis for the patient before they go home. So that's one thing. So, and also you have to make sure the patient knows if they have to follow up with certain people. like mainly the primary care follow-up, to go over all the medications or to go over the plans for the medical conditions, or any post-surgical follow-up if the patient had a surgery, or any other important follow-ups, or the continuation of therapy services follow-up. So all the follow-up appointments need to be set up. So home services, equipment setup, and follow-up setups, and also medications. You need to reconcile all the medication at the time of discharge, just like you did like admission reconciliation for medications. You have to do a discharge reconciliation also for the medications, to make sure what medications to continue, what medications to discontinue, what medications to slowly wean off, so these are the things, what medications you need to monitor from time to time, like a warfarin or coumadin that needs to be iron or needs to be monitored from time to time. So these are the things that you have to carefully review all the medications, make sure and discuss with the patient or the family, and do something called discharge reconciliation. Not only reconciling medication, but also you have to send the scripts to the pharmacy, whichever pharmacy they go to usually, like at least a day before, so they get the medication on the day of the discharge, and make sure the pharmacy actually get those scripts on time. This is also very important, because the patient might be in the hospital system for a long time, like say 1 month, 2 months, and now they are going home. They have to settle down, and then they have to make sure they have the medications, and then they have to contact their primary care to get an appointment, for a follow-up. So all these things have to be lined up for the patient. You have to explain everything to the patient. And another most important thing is patient information, like for example, what are the precautions, discharge recommendations. Say for example, if the patient has some kind of activity restrictions related to any surgery, or a spine surgery or a fracture surgery, you have to discuss those activity restrictions. If the patient needs to be on some kind of bladder program, bowel program, you have to discuss those things. If the patient is going home with a Foley catheter, you have to discuss how to manage it, properly. Or if the patient is going home, with some orthopedic or orthostatic precautions, you have to discuss how to manage your blood pressure, make sure how to avoid falls at home, those kind of things. So all those instructions have to be very clear and concise, and discuss those things, with the patient, the family. Like diet orders, what kind of diet you are prescribing to this patient, why it is important to be consistent with the diet recommendations, like solid food consistency, liquid consistency, and precautions related to the diet, especially when it comes to stroke patients or brain injury patients or any neurological patients, where something's related to their cognition, your mental ability, or their swallowing function. Then those things become very important. And if they are going home with peg tube feeding, you have to order appropriate tube feeds, what dosing, what duration, everything has to be crystal clear in the discharge recommendations, and everything has to be communicated with the patient or with the family member, close family member, so that they know exactly what to expect, when we discharge the patient home. That's why we do something called family training program before discharging the patient home. That means we invite one of the close family members who is going to take care of this patient, and then we discuss everything with the patient and with the family member, to know, to bring them up to the speed. So what to expect, how to handle the patient properly, how to take care of the patient's medications, how to take care of the patient's any precautions or activity restrictions at home. So this is very important. So the discharge process is much longer than the admission process, but it's very important to be thorough with the discharge process. I will tell you this: when, say, if you're on call resident, and say some nurse from the floor calls you, saying that so and so patient is leaving, the patient needs a discharge order. Please do not open the computer and put in a discharge order blindly. You know why? Because if you don't know about the patient, and if you're blindly putting a discharge order, you have to make sure, does the patient have, all the medication sent to the pharmacy, all the instructions entered for the discharge, there's a proper discharge summary printed out, because when you print out the discharge summary, it has to show what medications the patient need to take, where the patient should go to get these medications, what are the follow-up appointments, where they should go for the follow-up, who they should see, what are the important instructions the patient need to know when they go home to monitor. So these are the most important things that should show up on the discharge visit summaries. There is another discharge summary document that we are going to discuss in the next video, but these are the important things that you have to keep in mind when you're doing a discharge process. It has to be thorough, it has to be clear, and it has to be step-by-step manner. I hope you like this video, and I hope to see you all in another video. Thank you.